Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Well, good morning, everyone. I'm super excited today to actually have Dr. Yele Aluko with me. I hope I didn't twist the name too much, but I will give you a chance to introduce yourself. And Dr. Yele is actually a renowned cardiologist who, just like myself, walks in the lane of integrative cardiology. And he brings his view to integrative cardiology from a different perspective, from a different vantage point, from the vantage point of health equity and how that relates to the epidemic of chronic diseases that we're actually seeing right now. And that frames the discussion in very different terms, not just for our patients, but also for our practitioners. So Dr. Yele, I'm going to ask you a question that I ask every single guest on my show. How did you grow up to be who you are today?
That's a very interesting question. And I want to, first of all, thank you for having me on your podcast. I was 15 years old. I was 15 years old when I made the decision to become a doctor. I saw a person die in the emergency room of a hospital in my home country of Nigeria. My mother and I had gone to visit a family member, and a patient was wheeled through the emergency room in cardiac arrest. I was 15 years old. She died in the emergency room. Her husband was there. I remember his piercing wailing and all the chaos that was going on in the emergency room. And that was the day I said I was going to become a doctor. Why did I say that? I was a young teenager, altruistic, naive. I thought that if I became a doctor, I would be able to prevent any family member of mine from suffering that fate. One thing led to another. I did become a doctor, and I'm also a cardiologist like you.
Okay. And so what happened during your cardiology journey, right? Because for me, it was sort of an evolution that started somewhere, maybe like 10 to 12 years into my cardiology career. I sort of walked one day into my hospital area, and I was a section chief at that time for nuclear stress testing, and I saw all these patients lined up, and some of them were so young, and I said, there must be something we're doing wrong. And I decided to figure out what is it that we are doing wrong, because we were doing a lot of things right, but there were a lot of things that we were doing wrong. So, so this is how I emerged, I guess, as an integrative cardiologist. But what about your journey? Tell us, as a cardiologist, how did you evolve?
Well, you and I actually trained at the same institution at Cornell Health. Weill Cornell Health is what it's called today. Mm-hmm. When I was there, it was New York Hospital. I did general cardiology, and then I did interventional cardiology. And after I started practice, I became a structural heart cardiologist. These are all terminologies that describe the spaces within which we work as cardiologists. So I was the doctor that would be opening up blocked arteries with stents and balloons. I was also the doctor that could put a new heart valve into a patient without opening the chest. Now, what I realized along this journey was that in the heart catheterization lab where I did most of my work, I could most often save the life of a patient in front of me. That was real, tangible, concrete value. But over time, there was a building up of frustration that I kept seeing similar patients coming back with the same kind of preventable disease. And these recurrences were shaped by forces that no procedure could really fix. Now, I went to business school later in my career, and it was when I was in business school sitting in an organizational strategy class, I realized something very fundamental. I realized that the way healthcare is administered, in other words, the strategy behind the healthcare industry, is not positioning the industry to be successful in preventive health. It doesn't support what we call population health. I realized that our health system wasn't poorly run. It was actually performing exactly as it was built. It was just built for the wrong thing. It is designed to be a sickness industry, an illness industry. And once you realize that this is the design problem, you can't get away from the fact that the fundamental problem is not at the bedside. So therefore, I began a quest to see how I could begin to message the design flaws that led to patients that came to me. That was my aha moment. And it was 2 years after that I made the very difficult decision to retire from the bedside and to move upstream to Big Four health industry consulting. I became a health consultant, and that provided me the opportunity to bring my knowledge upstream. And the intent was to be able to impact the industry itself in a more transformative manner.
So how, tell us an example. How can one, because this is such a common issue with so many patients, right? Patients come in and patients say, my doc is not listening to me. I have all these questions and all they want is to drop a prescription, right? So patients that typically see me, they say, my doctor said I must be on statin, I must be on this, I must be on that, but I want to understand what's going to work for me. How should I manage myself? And that shouldn't be just drugs. It has to be diet and exercise and everything else, right? So how did you work? Did you manage to shift the focus, reframe the problem on that bigger consulting stage? Or, in other words, were you able to change the course?
No. The course will not be changed until health policy, execution and accountability for health policy, and specifically if we don't have a policy around population health that prioritizes prevention, prioritizes eliminating the adverse, what we call the social determinants of health, means the risky environments or behaviors that can cause illness. If we don't impact things at that level, we can't fix the problem. So the problem has not been solved, and it's not going to be solved until more of the advocacy issues, such as having universal health insurance that provides access to health care, such as having improvement in health literacy, and having accountability for care, not just fee for service, where the whole industry is centered around profit. But you bring up a good point in that you have patients that are asking you questions as to how they can empower themselves. And as a cardiologist, you will relate to the fact that a lot of the problems we see in cardiovascular medicine are driven by, yes, cholesterol, but also by inflammation. Very few cardiologists can connect their day-to-day work with where the disease actually starts. And it starts way before people end up in your clinic or in my Cath lab. So my world, when I was practicing, I was treating blockages in the arteries, but that blockage is the end stage of a long metabolic process that probably took 20 years, and it includes obesity, includes insulin resistance, type 2 diabetes, something we call the metabolic syndrome. The audience may have heard of polycystic ovarian syndrome. These are all driven.
It got renamed recently, right?
It got renamed just about a month ago. Polyendocrine metabolic ovarian syndrome. And that speaks to the following. A gynecologist is treating a woman who has polyendocrine metabolic ovarian syndrome. That gynecologist most often isn't thinking about the cardiovascular risk that is already happening. The hepatologist, the liver specialist who is treating a person that has fatty liver disease, isn't thinking about the fact that the problem is beyond just the liver, isn't really focusing on the fact that the liver disease is because of something else. The kidney doctor who is managing early kidney disease, and even the ophthalmologist who is looking at your eyes, that is seeing some diabetic changes in the retina. The specialization of medicine is built such that each of us is looking at our own organ. There was a running joke when I was a fellow where we would say, I'm a doctor below the neck, above the waist, on the left side of the chest.
Well, you didn't, in my fellowship, and when I wasn't attending, we would call our fellows to say, are you a plumber or are you an electrician? You would have been in the plumber category because you were in the Cath lab, and the AP docs were the electricians, and us cardiac imaging docs, they did really have a moniker for us. So they just call us non-invasive. And at one, exactly. We're the photographers. We're taking pretty pictures.
Yes. But the point I'm making is that this metabolic storm, this insulin resistance, it doesn't respect specialty boundaries. It creates devastation throughout the body. It damages the liver, the kidneys, the blood vessels, the eyes, the heart, and it starts very silently and it builds up for decades. Now, the fragmentation that we approach our patients with is not a clinical accident. It's the way the system was designed. I'm a super specialist, and my job was to open blockages and put valves in without giving much regard to what happened before. But like I said, I had an aha moment, and I have shifted my focus to trying to understand the health policy decisions that are made. Why do we not have universal health coverage in America? Why do we have health disparities? Why do we not prioritize population health?
Mm-hmm. Very interesting. And, I think this is so important because a lot of the times patients are sort of very much focused on measures of end stage of disease, right? For example, calcium score or identifying plaque composition in the coronary arteries. Not that those aren't important, they are profoundly important, but they are sort of the late stage of disease, right? They're the end stage. And so how do you see it? Let's say a young person is listening to us. Let's say they're in their late teens, maybe they're early to mid 20s. What would you tell them to do right now so that 30 years later, 40 years later, they are not on the table in your cath lab? What should they be doing or not doing?
Well, fundamentally, individuals need to take ownership of their health. What do I mean by that? A 20-year-old man or woman should understand what type of health illnesses populations are exposed to. And if we talk about a 20-year-old man whose father or grandfather had a heart attack, What causes a heart attack? And we need to start fundamentally. What is a heart attack? Health literacy is very important. And I emphasize that because only about 11% of the American population is proficient in health literacy. So we need to know about risk factors for different common disease entities so that you can avoid them. People have to learn how to make responsible personal choices in regards to the diet, in regards to lifestyle, such as physical activity. You need to know the consequences of what might happen if you do not engage in physical activity on a regular basis. You need to understand the consequences of what happens if you smoke and if you drink alcohol in excess. You need to understand the consequences of some things that are out of your control. If you're exposed to environmental pollution, you need to understand the consequences of living in neighborhoods where you don't have access to healthy food, the consequences of buying ultra processed food from grocery stores. We have to know what all of this does to us. A 50-year-old man needs to understand that prostate cancer may be diagnosed as early as the age of 50. And when you go to see your doctor, if you're a 50-year-old person, there needs to be a checklist as to what you need to understand you get out of that appointment. You need to know what your vital signs are. Are you at risk for any cardiac problems? So you need to know your blood pressure. You need to know what your BMI is. You need to know what your PSA is. You need to know the metrics you should ask for, and you need to track them longitudinally over time.
So you were saying that a lot of work on the part of a patient goes to advocate for themselves. And I see that as a big issue in our healthcare system, because just as you mentioned, the healthcare literacy is low. Young people, they feel young, right? It's difficult for them to sort of envision what's going to happen 20, 30 years down the road. And the discussion gets framed within these specialty bounds, because I even see, for example, and it's very frustrating to me, you mentioned gynecologist managing polyendocrine metabolic ovarian syndrome, or even managing hormones for women, for example. And rarely, if ever, they actually look at the most significant driver of mortality in women, which is cardiovascular, right? So we're suffering from this tunnel vision consistently. So what would be, the practical steps? Let's say we're going to go into top 3 in your book. Let's compare yours to mine. What do you consider the top 3 must-do lifestyle intervention for any individual, I would say at any age, to overcome environmental disturbances, insulin resistance, this whole sort of to change the landscape in which the metabolic storm is about to arise, right? Because we're all going to have some sort of a metabolic disturbance as we get older. We know this, that insulin resistance, especially tissue level insulin resistance, is a problem that is associated with aging. Hallmarks of aging are pretty clear on that. So our impaired nutrient sensing is one of them, and all sorts of deregulation. And so what are the top 3 in your book that you would say everyone must do, at least these 3?
We should understand that we are products of the things we put inside our bodies. And by that, I'm speaking to diet and lifestyle choices. If you're eating a heavily ultra-processed diet, or diets that are laden in calories, then you are creating a substrate where a metabolic storm can thrive. So you need to know your diet. You need to eat healthy. Secondly, you need to control what are the elements you're putting in your body, such as smoking and such as excessive alcohol, because in combination, all of these things create that environment where your body is vulnerable for metabolic disease. And metabolic disease can lead to illness and damage multiple organs. What do you put in your body? That's number one. What's your diet? What's your choices? Number two is it's important that the body is not sedentary. Regular exercise of some form is important. And I'm not saying that one has to go to the gym every day, 7 days a week, but one should develop the discipline of having some kind of schedule. Twice a week.
Consistency.
Yeah, consistency.
Be consistent.
The word consistency is perfect because it is consistency, not intensity. Okay. If you work out like a fiend for 1 hour on a Monday and you don't come back for a month, you're not doing yourself any justice. So consistency. And third is try to be more aware about what your personal medical risks are. If you have
personalization, personalization.
Precisely. Risk personalization helps you understand what your individual risk may be. Do you have high blood pressure? Is it controlled? Having it is one thing. Is it controlled is another. It must be controlled. If you have abnormal lipids and you don't like taking medications, understood, then you have to give it a good, real try at dietary modification. 1 month, 2 months maximum. Because if it doesn't work, and we have to be honest with ourselves, as you know as well as I do, that some people are predisposed to, genetically to high cholesterol levels. If you're one of those people, diet may not work. And if you've given it a shot for 2 to 3 months, it's still high, you're at a crossroads. You must make a decision. You must know that a high cholesterol is linked with heart disease. The way to avoid that risk is to lower it. You've tried dietary intervention, hasn't worked. It's a good idea to go on a cholesterol medication, bring it down to normal, and then you have another option. You can go off it and then see if it stays down with disciplined dietary regimens. But if it goes back up, then you happen to be a person that needs medications.
So this is a great approach, and I think in many ways it parallels what we're doing here at the Holistic Heart Center. So we actually run an app called Heartwell.ai that models person's risk in real time and allows us to pick appropriate nutritional interventions, medical interventions, supplement interventions to really show a patient how they can reduce that cardiovascular risk. Because I think what you bringing up here is very important, is that cardiovascular risk is a composite. And it's not the greatest composite because most of it is derived from population level data. And a person in front of us may or may not be a good fit for those populations that were studied. So that's where that personalization comes in, and being able to model the impact of various interventions before they're able to happen is an opportunity for patients to actually be proactive, to take control. Because even within the sort of top 3 that you discussed, I would say that there is so much variability, right? There is so much variability in the nutritional approaches. There is so much variability in the exercise approaches. Yes, we know what works in different populations, but once we have person's genetic data and biomarker data, and even information where they're coming from in terms of their zip code, we're able to model something that is more specific to them. So, it is a process. Now, I'm curious because I know in your work, you're also using artificial intelligence. I use artificial intelligence daily, that whole Heartwell AI is a agentic AI platform, and I'm, full disclosure, I'm the one who made it, so hopefully other people will use it as well. But we use it for a lot of our patients. But how do you see the role of this new technology, AI? Do you believe that it's going to open the doors for us for a better population health opportunity, or even resolve some of the healthcare inequities? Or is it going to be just the opposite?
Very important question. I think that artificial intelligence is probably by far the most disruptive technology in the history of humankind. To answer your question, how is AI going to impact health? Is it going to make it better, make it worse? Is it going to close health equity gaps? And I'll say the following: AI can do both. It can both close gaps or blow gaps wide open. It can improve health or make health care less accessible. It all depends entirely on us, not the technology. When I say us, I'm talking about industry leaders and industry health consumers. Let me start with the fundamental principle that technology in of itself, it enables a strategy of an organization. It doesn't create a strategy. AI is a multiplier of good things and bad things. If you drop it into a system, it amplifies whatever the system is already built to do. So if you have a system that doesn't prioritize population health, if you drop AI into it, it's not going to improve population health. If you look at what our system is built to do, technology and the industry in general tends to produce point solutions. And left to that logic, AI will do that. It will do it faster. It'll do it cheaper. It will do it at scale. It can produce 1,000 brilliant point solutions. Now, that is from the industry perspective. From the person perspective, AI indeed is going to help people understand quicker, more efficiently, and in a more understandable manner what's happening to their bodies. With all the devices, all the wearables, you can understand real time what's happening to you. You can understand real time what therapies are out there. You can understand how to interpret clinical trials that ordinarily you just didn't understand, and how that particular trial, and you mentioned this, we have statistical variances, is what is being said about a medication working for this particular disease because of a clinical trial. Does that actually reflect your own personal biology? Yeah. So the outcome from AI is going to be dependent on exactly how it's deployed within the industry and how individuals use it. The current industry is optimized for fee for service, for transactions, and AI will make that quicker. But it isn't solving the problem of lack of universal health care.
Yeah, that is very true. And I have to tell you that, like every physician, I have patients who come and they, already populated, or they uploaded their laboratories into one of the AI chatbots, and they have a whole sort of a printout. But I recently gave a presentation actually at the annual conference for the Institute for Functional Medicine. And I realized as I was preparing for that presentation that research is actually very troubling, because researchers from Stanford have documented that as AI models advanced in their capabilities, they dropped medical disclaimers from their answers. So an individual going into an AI chatbot nowadays and putting in whatever information they're putting in and potential opening the door to hallucinations as well actually doesn't get most of the time a warning that this is a machine and not a medical professional. And and that creates a situation where I think patients, because they are trying to make themselves better, they are certainly trying to personalize interventions for themselves, as you mentioned, because of the lack of universal healthcare, because of the lack of access. AI becomes that surrogate medical advisor, but that medical advisor very often may take them down the wrong path. So when I was at a conference, I gave up an example that was a real life example because it was in the Facebook group that as a physician I belong to. And it was a patient who gave their physician this very long prompt that was advising them to upload the real labs into AI chatbot, which of course is not HIPAA protected, and come up with cardiovascular wellness score. And I asked my audience, I said, have you ever heard of cardiovascular wellness score? Because there really isn't one, right? We have our population metrics, but this patient is asking AI to take their labs and invent that cardiovascular wellness score. And they're going to trust it because, it sounds very convincing and it sounds very personalized, but it basically doesn't exist. So we are, as you said, it's compounding the problems. It could make things more efficient, but it also could compound the problems. So how are you using it in your work? Are you looking at it from, how can it increase health equities? How can it reposition how we approach patients as cardiologists? Like what is your take on it? What should cardiology do? Because we obviously use a lot of AI, mostly for ECG interpretation, echocardiogram interpretation, but in regular life, for any person who's listening to us right now, what advice would you give them? Let's say they want to implement lifestyle, exercise, nutrition, avoidance of toxins. Should they feed those desires into ChatGPT and see what it produces?
So I have a TikTok platform which I use to address health literacy issues. And this issue about AI is a question that I posed and answered. And the truth of the matter is that when people have problems, oftentimes doctors aren't available. AI is available 24 hours a day. I think it is good to understand how AI helps, but also to understand why you should be wary about what AI says. A lot of this depends on the prompts that you put into AI. As a patient, if you say that I am having severe headaches and I've had headaches for a month, what could it be? A brain tumor is going to come out of AI. And
it will come up and just be in the very bottom.
It may be on top. It all depends. It might be. And even if it's in the bottom, a patient that sees that brain tumor is going to freak out. So one has to understand that you have to be fairly explicit in what you put in. I am a 56-year-old Caucasian woman. This is my medical history. These are the medicines I'm on. I'm having some new symptoms of XYZ. I'm going to see my doctor, but I want to be informed before I go and see my doctor. That narrows, AI is pretty good when you give it the right information.
Mm-hmm. When you give it guardrails and say, you're not my doctor, but I want to be prepared when I see my doctor.
Now, whatever it sends back to you, you should digest that and not take it as gospel truth, but it's at least educating you to some degree. Some people use 2 or 3 AI platforms. I would do the same in a second one and see what happens. AI is also important when a patient is going to see their doctor. Generally, you may have 15 minutes with the doctor. I know that in your practice, integrative cardiology practice, it's much more personalized. But for the run of the mill clinical visits, you may have 15 minutes or 30 minutes. And sometimes the clock starts clicking before you sit down. So it's important to understand what you want to get out of that visit, write them down. You know, why do I need to change my medications? Explain to me why. What are the side effects of these medicines? How are we going to check and when if they're working? And AI can help you actually draw up the top 3 questions you need to ask. You can't have a list of 10 questions because the appointment will be over before you get to your 10 questions.
Well, in traditional appointment, not an integrative cardiology appointment, but in traditional.
I would agree with that. Now, with AI still is also a value in integrative medicine and integrative cardiology. It makes you a more informed and responsible healthcare consumer.
100%. And actually, at Holistic Heart Centers, we have a patient education community. It's called Holistic Heart University. It has some free resources and, of course, a little bit more resources with paid membership. And regularly, patients get education on various medication, on supplements, on nutritional plans, because there's so much information down there, so much research coming out. And honestly, people are struggling to understand. And we know that even guidelines that we produce as cardiologists, they take years to be implemented into practice. And even when they do get implemented, they get implemented not far from 100%, right? It's much below that. So I'm curious, let's pivot a little bit, because something that you said earlier in the conversation is a very interesting area to me, and I'm trying to understand it a little bit better. And that's the effect of the environmental impacts on this sea of metabolic disease that we are seeing, right? So when you are thinking of it, in terms of how does environment actually shapes our chronic disease trajectory, what are the things that you look for first and foremost? What are sort of, again, we're going to go to the top 3 analogy. What are the top 3 things for you that you would say, these are the most impactful environmental things that we need to address in order for us to start putting brakes on this chronic metabolic storm?
I'll speak to 2. And one is understanding if you are being consistently, I'll speak to 3. If you're being consistently exposed to environmental pollution, you go to work.
Right.
How do you go to work? Are you being exposed to a toxic environment by way of fumes, depending on the kind of work you do? Are you living close to places that, like a nuclear plant, some kind of environmental plants that spew out environmental toxicity? Talking about AI, it has come to be known that the AI infrastructure is creating a significant amount of environmental pollution. So that's one. And the second is, do you have allergies? And what is your allergy profile looking like? Many people don't know that they are allergic to things. And getting an allergy profile, I won't be surprised if you do these profiles in your office, may yield very, very, very startling results that people are walking around with a host of allergens that they get exposed to, and they very quietly have already developed a quiet metabolic environment that's just waiting to become a storm. And the third is sometimes inside buildings, there's an important impact that buildings, where you live, where you go to work, have an impact on your health. Quality of indoor air. Okay. How is your ventilation? What kind of particles are swirling around in the places that you are working 8 to 10 hours a day, that you are inhaling with every single breath? Okay. Currently, I am a co-chair of the Global Commission for Healthy Indoor Air, where we're looking at how one can systematize across countries regulations about indoor construction. Okay. Such that the construction is held accountable to ensure that indoor air is as clean as it can be. So, oblivious to many of us, is just walking outside and staying indoors can actually be exposing you to environmental toxins.
Very interesting. I also read recently that since so many people usually work indoors, right, or let's say work from home, if they don't take time to step outside, even just for like 10 to 20 minutes per day, they may develop red light deficiency because the natural light spectrum includes all wavelengths, including the red light. And the one that we have indoors, because of the LED lights and energy saving lights, which were certainly, seem like the right thing to do to save energy. But those actually are blue light devices. And so they make us red light deficient. And of course, this red light deficiency potentially affects our mitochondrial health, our ability to derive energy from our mitochondria, could potentially open door to some chronic diseases. But, so I think we are very much under evaluating the impact of the environment, not only in terms of exposure to various chemicals, but even in terms of social deprivation. Like, for example, I worked quite a bit in inner city neighborhoods here in New York. And I learned firsthand what social deprivation actually could do to patients. And there is only one risk assessment tool that I know of, the one recently endorsed by the lipid guidelines, the Prevent score, that actually has an area for the zip code to go ahead and calculate the social deprivation index. And what's interesting is that we run Prevent as part of the Hartwell AI because it computes all the risk scores. And I'm yet to see a zip code that would say low social deprivation index. I'm beginning to think it doesn't exist because everything is coming up at least moderate or high social deprivation. And I'm like, that shouldn't really be happening because a lot of these patients are from areas that one would consider very well-to-do areas. But that zip code, it says, no, this is moderate social deprivation. And so this is a sort of like a whole body of literature, I think, needs to give us data, give us studies, give us an understanding of how to find these root causes that are pushing people into metabolic disease, pushing them into insulin resistance, because that's what we can control. That we can control a lot of it, right? We can control it in our neighborhoods, we can control it in our indoor environment. So very curious that you mentioned the global commission. Is this global commission on the buildings, is it just that some countries have regulations and some countries do not, or like how does that work?
So that is exactly what it is. There are regulations that are inconsistent, and depending on the countries, there might be none. And the feasibility to actually execute on some of these things and developing the infrastructure and the governance structures and platforms, it requires government leadership, alignment, as well as financing. But even in the industrialized world, there is a lack of standardization. And what the Commission is seeking to do is to develop a global platform for education and opine on best practices and how current best practices can even be further optimized. And of course, leading with the fact that indoor air impacts human health. Yeah, and this is being done because of that reason.
Very interesting. So we had a very interesting discussion, I think, right? We touched on a lot of kind of areas. Let's hear your predictions for the future. What do we see in the next 5 years in cardiovascular and metabolic health? What do you sort of foresee from your viewpoint will be the areas where we're likely to see the most life-changing discoveries or progress, for example? What would you want those areas to be, and what do you think they're likely to be, right? Because what we want and what we get is not going to be the same. So it's sort of predict the future. Dr. Yele, tell us what the future holds.
If one goes with the trajectory of American health, innovation has yielded significant transformation. And, a transcatheter aortic valve implantation is an example. Drug-coated stenting is another example. There is no question that we will continue to do those types of laser-focused, individualized benefits going forward with AI. We've been doing it already, and AI is going to make us do it even better. I do believe also that health systems will become more efficient with what they do. And therefore, a Mayo Clinic, a Cleveland Clinic, a Johns Hopkins, a New York Hospital, Cornell Health, Mass General, the marquee institutions will become even better
at managing those complex end-stage conditions.
Managing within the bricks and mortars. Okay? I look at health not as episodic. I'm sure you do as well. I think people are born, they navigate life, and then they get sick, and then they go into a facility, and a lot of activity happens. They get treated, and then they're sent back out. We should be looking at health from when a child is born, when they mature, collecting data along the way. And then when they get sick, they go into hospitals, things happen, but then they get well and they come out, and there's longitudinal data collection in and outside of the hospital. Right now, we have most of the data collection occurring episodically.
And it's siloed, right? Even as a patient, like so many patients, part of the things that we do when we work with new patients is that we spend a lot of time to collect their medical information. That's actually, they may get like a 30 or 60-minute visit, but the amount of time to collect their medical information is at least 3 to 5 times longer, so that we can actually have an understanding with what's been happening with them. It's something so basic as just having access to medical records is still a huge issue.
Yeah, that's very true. Now, having said all that, I do believe that there are going to be technology companies that evolve, that are AI focused. There are many already, but there are going to be a few that are going to be positioned to really make a difference. And they're going to probably be sitting outside of the health industry. And they're going to require venture capital funding as well as private equity to sustain them through the first 5 to 10 years. These companies are going to be able to do the following. They're going to be able to predict illness. And then they're going to be able to prevent it because of that prediction. The third thing they're going to be able to do is when they predict illness that can be prevented, they'll be able to personalize the approach to the treatment. All those three are outside of the health industry. And I don't believe that the health industry itself, absent of a significant 360-degree turnaround of health policy, because health policy is supporting illness, supporting hospitalization.
Because illness pays, right? Illness pays the bills.
That's correct. When we start talking about prevention at scale, then it needs to be developed outside the industry, and a business case has to be built around it, which it'll happen. And I think that's going to be the most transformative aspect of AI.
I agree with you, because I think I'm seeing obviously Perplexity Health and Claude Health. And recently I spotted Amazon has a health AI agent. I actually played around with it. It pulled my medical records within minutes, something that I have trouble even doing myself. So I do think that we are coming into the era where private personal health agent will be something that every person will be able to have to serve as a guide that shapes trajectory of their health. And I completely agree with you that it will be outside of the healthcare systems. Even though the healthcare systems, their work is extraordinarily valuable, we do need procedural physicians like yourself who are putting in valves that save people's hearts. But, we have this unique opportunity right now to build truly a personalized preventative approach that didn't exist before, if we do it right. So the future is very exciting. And Dr. Yele, thank you for speaking with me and, sharing your wisdom and your perspective. I wish there were more cardiologists like you. If you are a cardiologist listening to us, please give me a ping so that you can be on the show, and we can discuss what the future holds for cardiology.
Thank you very much, and congratulations on the work you're doing.
Oh, thank you. Same to you. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.